Good afternoon to you once again. And actually, I'm filling up for Professor Georgie Abraham, who couldn't make it because of some problems. The key to a successful chronic peritoneal dialysis is the permanent and safe access to the PD. And it's been seen that the catheter-related problems are the second most common cause for transfer for patients to hemodialysis. So therefore, care has to be taken at the time of placement of the catheters for peritoneal dialysis to minimize transfers to PD. Now, there is various methods of insertion of the catheter. You can have a percutaneous guide wire technique, which is either performed blindly or under fluoroscopic guidance, or open surgical dissection and laparoscopic implantation. Most nephrologists would do the percutaneous technique. Some would, of course, there are some nephrologists who would be bold enough to do the laparoscopic implantation, but that is generally in the domain of the surgeons. And this is a US study which was published in 2007, and they found that conventional laparoscopic insertions of PD catheters, the surgeons were most commonly called for to put in these catheters. The number of nephrology insertions was as low as about 3%. Now, but there are certain problems when the surgeons do this. Very often, as you all know, that these procedures are delegated to the lower-level trainees, particularly in academic centers. Catheter, you must remember, catheter placement has been perceived as a low-complexity procedure, and surgical trainees may not have received adequate training and experience in inserting a PD catheter, and therefore trainees are very often left to figure out the details of the operation by themselves, and they are not aware of the latest advances of catheter implantation in many situations. Whereas the percutaneous catheter insertion, it does not require expensive operating time, there's no requirement of a surgeon or an anesthetist, there's a shorter hospital stay, shorter break-in period, and it's been reduced in many studies from 2 weeks to 2 to 3 days. And a study from Vellore actually suggested, a large study which said that percutaneous catheter insertion by a practicing nephrologist provides a short break-in period with very low mechanical and infective complications. And this study, which looked at the safety and efficacy of percutaneous catheter insertion, published in NDT in 2009, where they looked at about 150 catheters which were inserted surgically, and they compared the 883 catheters inserted percutaneously. And they found that the technical failure rate in the percutaneous technique was less than 10%. It reduced the dependence on surgical equipment, OT staff, and anesthetists, and reduces the risk of cancellation from overbooked surgical theaters. And when they looked at the various complications like poor initial drainage, dialysate leakage, the percentage of patients on PD at 1 month and percentage of PD at 6 months, and the median length of hospital stay, and they compared the two groups, they found that the problems were either similar or lower in patients who were in the percutaneous. And when they looked at the infections, the possible exit site infections or possible central wound infections and peritonitis at the end of 1 month, again, to their surprise, they found that it was lower in patients who had a percutaneous insertion as compared to those who had a surgical insertion. And the number of patients who were staying on PD who had a percutaneous insertion was much more over the years as compared to those who had a surgical insertion. This is again a meta-analysis of percutaneous versus surgical insertion, 13 studies of about 2,500 patients, and they found there's no difference in this 1-year catheter survival in between the two groups. Catheter dysfunction did not differ significantly, and the prevalence of PD fluid leak was also similar in the two methods or two techniques of insertion. But what they found interestingly was a significantly lower incidence of peritonitis in the percutaneous group. And this is just to show you that the diamond is almost in the center with a PD catheter survival or PD catheter dysfunction. But when they looked at PD catheter-associated peritonitis, it was in favor of the PD catheter being inserted percutaneously. There have been certain criticisms of the percutaneous approach. And the surgeons have said that since this is done, the positioning of the deep cuff is in the subcutaneous tissue external to the muscle fascia, and the use of midline point of catheter insertion, these are two weak points they're suggesting in the percutaneous approach, because subcutaneous and midline tissues do not provide adequate tissue attachment to the deep cuff or sufficient embolization of the transmural catheters, and therefore can lead to migration of the catheter or superficial cuff extrusion. It's been seen that One of the important factors which has led to the growth of PD is the insertion of catheter by nephrologists. And the number of catheter malfunctions actually comes down when the catheters are inserted by nephrologists. And in this study, they found that the PD take on the rate increased from 19% to as much as 17.6%. So PD penetration will increase if the onus on catheter insertion is on the nephrologist. So who should place the catheters? Anyone who's well trained in doing it, depends on your local expertise, nephrologists, surgeons, or interventional radiologists. And as nephrologists, we need to take a lead in this because these patients are more attached to us and we know their problems better as compared to referring them to some other unit. So I think we have to learn the art of inserting the catheters, and it would help our patients in the long run. I will just bring in one point, and this may be for the discussion, whether we would be open to litigation. And as nephrologists, do we have the training to perform surgical procedures, and are we protected by law? Thank you very much for your attention.
Comments from the surgeon first.
I think you're absolutely right. It is all to do with training. I don't think it's a turf battle. We are all looking out to the best outcome of the patient. That's the basic interesting part. So I think it's all to do about training, because getting this procedure done by a well-trained, interested, involved nephrologist is much better than an untrained surgeon who's just about, as you very rightly said, the last guy, last list, last patient on the table, everybody's gone home and he's just gone and stuck in a catheter somewhere. So that is absolutely correct. And I'm convinced now that actually, as you very rightly said, acute dialysis should be started off with peritoneal dialysis, build a fistula at that time, let it grow up, and then as and when required, you can start using a fistula. Try and avoid lines as long as possible.
We were going to have this topic actually, which we couldn't accommodate here, was on embedded PD catheters. So you talked of acute kidney injury, but even for CKD, like you place an AV fistula, whether there is a role for embedded PD catheters to be used as and when required. Any opinion from the house of embedded PD catheters or any experience?
We haven't had any experience, but I think Dr. Parak is really making a very controversial statement that PD is for AKI and hemodialysis for ESR. I think that is ridiculous. So he's talking about embedded catheters. We haven't embraced that. I think when the patient gets up, it's been a tradition since the 1950s that a fistula is put in, and the patient asks the nephrologist, I have a fistula, so why the damn are you asking me to do a PD? Similarly, if we have a practice of putting PD catheters and no fistulas, and you suggest hemodialysis to them, they're going to say, what the hell, man, I've got a PD catheter, I want to start PD. So a doctor is not the moralistic person here to decide what therapy. The option has to be given to the patient. So you are again suggesting, second time, that AKI let it go to PD and let the MHDs come to, it's not acceptable.
Okay, Jasuja says that there is a separate arena for the boxers and can be done later. Yeah.
Just to answer, Amit has raised an important question about training for peritoneal dialysis. But I would like to tell you that PD is actually built in the curriculum of our both DM and DNB training programs. And since beginning, nephrology training has involved putting acute PD catheters. Putting the percutaneous PD catheters, if you go by conventional ways by producing ascites, is actually not very different. And the training is, even if you look at the ASDIN guidelines, which requires not a very extensive training before you are allowed to practice this. So I think one should not go away with this idea that percutaneous catheter insertion will start some litigation. The second thing is that at present, in some of the guidelines, they have gone on to laparoscopic insertion of PD catheters as the gold standard, especially if you look at the New Zealand and the Australian guidelines. But I still feel from the Indian point of view, we should practice and train our nephrology colleagues in at least percutaneous PD catheter insertions, and that would expand the pool of PD patients and also prevent some of these complications, both for chronic PD and also for acute PD.
Thank you, Dr. Sharma.